All right, let's dive right into this explainer. So, if you're gearing up for a big exam at school, or maybe you just really want to master how the human eye works, you are in the exact right place. Today, we're going to treat the eye like it's a high-tech camera, breaking it down into the ultimate, super easy-to-follow study guide. We're going to make it fun, clear, and focused on literally exactly what you need to know to ace this. So here's our game plan. We'll be hitting the basic anatomy and mechanics first, then moving on to vision and diagnostic tests, looking at common refractive errors, diving into major eye conditions, and finally wrapping it all up with meds and nursing care. Starting off with Section 1, Eye Anatomy and Mechanics. Think of this part as, cracking open that high-tech camera to see the actual hardware inside. Okay, so the eye basically has three main anatomical layers, and if you can remember what each one does, you're golden. The outer layer is your tough, protective casing and the front window. That's the sclera and cornea. Then you've got the middle layer, or the uvea. That's kind of the engine room, right? It's got the iris for color, the ciliary body for fluid production, and the choroid for blood supply. And finally, the inner layer is the sensor and the wiring. You've got the retina catching light with its photoreceptors, and the optic nerve shooting those signals straight to your brain. Now this next part is a massive test day favorite, aqueous humor fluid dynamics. It's actually a pretty cool pathway. So the fluid is made by the ciliary body, right? Then it flows into the posterior chamber, sneaks right through the pupil, enters the anterior chamber, and finally drains out through the trabecular meshwork and Schlemmich canal. Keep this drain in mind because if it gets clogged up, well, pressure builds, and we'll talk about why that's a total disaster in just a bit. While the front of the eye has that watery stuff flowing around, the back, the posterior chamber, is filled with vitreous humor. It's this thick, gel-like substance that basically acts like scaffolding to keep the eyeball's shape. But here's the kicker. As we age, that gel literally starts to liquefy. And when it does, little bits of debris start casting shadows on the retina. Bam! That's exactly why older patients start complaining about those annoying floaters drifting across their vision. Moving on to Section 2, Vision and Diagnostic Tests. So we know the hardware now. How do we actually test if the equipment is working? First up, visual acuity. You absolutely 100% have to know your abbreviations for the clinic. OD is the right eye, OS is the left eye, and OU means both eyes. We use the classic Snellen chart for distance, the one with the big E, and the Rosenbaum chart for near vision. But here is a really crucial clinical fallback for your exams. If a patient's vision is so impaired, they can't even read the biggest letter on that Snellen chart, you cascade down. Ask them to count your fingers. If they can't do that, check for hand motion. Still nothing? Test for basic light perception. Okay, take a mental screenshot of this cheat sheet right now. You need to match the diagnostic test directly to the structure it examines. So, tonometry measures the pressure inside the eye. Ophthalmoscopy looks at the retina in the back. A slit lamp checks the anterior or front structures. The Amsler grid, that is specifically for central vision and the macula. Ishihara plates test color vision, and parametry maps out the overall visual field. Definitely lock these pairs in for test day. All right, Section 3, Common Refractive Errors. Let's look at what happens when the eye's hardware just kind of glitches and doesn't focus light perfectly. To keep these straight in your head, focus on the anatomical differences. Think of myopia, or nearsightedness, as an eyeball that has just grown a bit too long. Because it's too long, the image focuses too early. It lands in front of the retina, which makes distance vision super blurry. Hyperopia, or farsightedness, is the exact opposite. The eyeball is too short, the light rays don't focus in time, and the image falls behind the retina, making near vision blurry. And then there's presbyopia. Now, the key takeaway here is that while hyperopia is an actual eyeball shape issue, presbyopia is strictly an age-related thing. It's the loss of the eye's ability to accommodate for close-up tasks because the lens just gets stiff as we age. That is literally why everyone eventually ends up needing reading glasses. Okay, pause. I need you to steer this number into your brain right this second. 10 to 21 millimeters of mercury. This is the normal range for intraocular pressure, or IOP. Seriously, if you only remember one number from this entire explainer, it has to be this one. Which brings us to Section 4, Major Eye Conditions. Knowing that normal 10 to 21 pressure range is absolutely critical as we look at our big disease processes. And the big one is glaucoma. This is where impaired drainage causes that internal pressure to spike, which crushes the optic nerve. You've got to contrast the two main types. Open-angle glaucoma is super sneaky. It's gradual, it's painless, and it just slowly steals away your peripheral vision.
But angle closure glaucoma, whoa, that is a sudden, immediate medical emergency. The patient is going to be in intense pain, they'll see halos around lights, and they'll probably have nausea and severely blurred vision.
Moving on to cataracts. So if glaucoma is a pressure problem, a cataract is a cloudy lens problem. The camera lens literally gets frosted over, causing painless, blurry vision. Patients will tell you about glaring lights, dimness, and weird color changes. But the great news here? The treatment is totally routine and highly effective. Surgeons just pull out the clarity lens and pop in a brand new crystal clear intraocular lens.
When we look at the retina, there's a really stark difference in how things present. Macular degeneration attacks central vision. A huge early warning sign is seeing straight lines as kind of distorted or wavy, which eventually progresses to total central vision loss. On the other side, retinal detachment is when the retina literally peels away from its underlying tissue. This is an absolute emergency. The classic signs? Sudden flashes of light, a massive swarm of floaters, and this terrifying sensation of a literal dark curtain dropping right over their field of view.
So we've gone through the hardware, the diagnostic tests, and the major clinical glitches. We know exactly what can go wrong. But how do we, actually fix it and care for the patient? Let's bring it home with Section 5, Medications and Nursing Care. This is where the rubber meets the road for your exams, wrapping up those crucial pharmacological rules. First up, ocular meds. Getting medication into the eye is actually pretty tricky because of our natural defenses. The eye instinctively wants to blink and tear up to wash foreign stuff away. Plus, the conjunctival sac is tiny. We use drops, ointments, and sometimes injections. A huge patient education point here, you have to warn patients that ointments will blur their vision temporarily. But we use them because they last much longer on the eye than drops do. Now, this step-by-step administration process is incredibly crucial for your tests. Step 1, you drop the medication into the conjunctival sac, never directly onto the eyeball itself. Step 2, and seriously underline this in your notes, always apply punctal occlusion. That just means pressing gently on the inner corner of the eye to stop the drug from draining into the tear duct and getting absorbed by the rest of the body. And step 3, if you're giving multiple drops, always wait exactly 5 minutes between them so the first one doesn't just get washed out. What about post-op? After cataract surgery, it's all about keeping that pressure down. Anything that increases intraocular pressure, like bending over, lifting heavy stuff, or straining, is strictly forbidden. The patient needs to wear a protective eye shield, especially at night. And most importantly, they must immediately report any sudden pain or those classic retinal detachment signs we just covered, like flashing lights or new floaters. When we zoom out, your absolute top priorities as a nurse really boil down to safety and education. Specifically, fall prevention is massive. You're dealing with visually impaired patients, so making sure their environment is clear of hazards is job number 1. You also have to be relentless about teaching them how to administer their own drops, using that punctal occlusion trick we talked about, and just making sure they actually stick to their medication schedule. Because remember, unlike a cataract surgery that completely fixes a cloudy lens in a single day, treatments for chronic conditions like glaucoma require lifelong therapy. There is no magic cure for glaucoma. You have to ensure lifelong adherence from your patient to keep that eye pressure down. Otherwise, they risk permanent damage to their optic nerve. And there you have it. You know the mechanics, the red flags, and the treatments. But here is a thought to leave you with. Considering how incredibly delicate and vital the eye is, how will this knowledge change the way you interact with and protect your visually impaired patients tomorrow? Keep studying smart. Rewatch this explainer anytime you need a rapid review, and we'll see you in the next one.